Here's chapter 10, recording 3. So we're talking about assessing a patient for abnormal breathing. So another sign of abnormal breathing is unequal or inadequate chest expansion. So one part of the chest rises different than the other, or it really just doesn't come up enough for them to take a normal breath. Increased effort of breathing. You can see this in the use of accessory muscles, so muscles that you don't usually use a lot for breathing. Now all of a sudden you're trying to bring them in. Shallow depth, so a reduced tidal volume. They're just not taking in a whole lot of air. Skin that is pale, cool, cyanotic, and clammy. So cyanotic is blue, remember, and clammy means moist, so they're sweating. So this typically means that they're not getting enough oxygen into the tissues. And so what their body does is it tries to minimize the areas that the blood actually goes because it wants to keep your heart, your brain, your lungs, and your kidneys having enough oxygen if it can. So it'll pull it away from your skin. You can see the skin pulling in around the ribs above the clavicles. This is showing that they're having an increased effort of breathing. That's actually what's called retractions. Even when your heart has stopped, your body naturally, because of survival instincts, will still attempt to breathe. The heart's not doing anything, but the brain is still active enough that it's saying, hey, you need to try and breathe. These are called agonal gasps. You did see this during the CPR portion. We also call this guppy breathing or fish breathing because that's kind of what fish do when they're out of water. They just try and take these big, sporadically timed breaths. Your body does the same thing. A different pattern of respiration is called Cheyne-Stokes. You often see this with patients that have stroke or head injury. So their breathing starts increasing in rate and depth, and then all of a sudden they have what's called apnea. So that relative flat line there on your screen, it's basically they don't have spontaneous respirations or spontaneous ventilation at this point. We still call them respers. There's also ataxic respirations. So they are just completely sporadic. They're all over the place. There's really no identifiable pattern. And these are people that typically have a pretty serious head injury. Kussmaul respirations are in people that have like a metabolic or toxic disorder. So you have deep, rapid respirations. Remember those people that retain CO2? CO2 is synonymous with acid. So they have acidosis. So this is a very common type of respiration pattern because they're trying to breathe off that excess CO2. Even though that patient may be ventilating, remember that respiration may be compromised. Some indicators that something's not right is the level of consciousness. If your patient is normally with it and now all of a sudden they're confused, they're combative, they're extremely tired in a way that's abnormal for them, it could be because of lack of oxygenation. They don't have that respiration taking place at the cellular level. Skin color as well. If you have enough oxygen within your body, your blood's going to circulate to all the different organ systems to make sure that everybody is getting the proper amount of oxygen. As soon as oxygen levels start to decrease within the body, your body starts prioritizing who gets that blood. So when you're not getting blood to your skin, it starts turning pale. You're not just considering respiration, you have to consider oxygenation as well. So we do assess this through the use of SpO2 monitors or pulse oximetry. We consider it a routine vital sign. Yes, there are ways to trick the machine so that it reads high when things are actually low and vice versa, but we still routinely put it on. So we want to keep that pulse ox at 94 or above. Most healthy people range between 98 and 100 on room air. When something starts impairing that oxygenation, the SpO2 is going to start to decline. In medicine, we try and go socks before shoes, meaning that you have to do things in a certain order, and you typically do them the least complex to the most complex. So first and foremost, we have to make sure that the airway is open. And that could be they've got it themselves, they're doing a great job, they're conscious and able to secure their own airway. Or if they're unconscious, you may have to open their airway for them to make sure that their tongue's not in the way, to make sure that that air can actually get in. When you're opening the airway of an unconscious person, make sure that you move their head as a unit. So you want to move the whole thing together. Generally, when you're going to position a patient, you're going to put them supine. You're going to put them on their back because that seems to be the most effective position for them. If you find a patient that is lying face down or in the prone position, you need to roll them over. You don't need to add extra obstructions. They've got enough going on inside with the tongue. We don't need to add something up in their face, making it harder for them to breathe. The head tilt chin lift maneuver is used for patients that don't have a suspected spine injury. If they have a suspected spine injury or could potentially have one based on the mechanism of injury or nature of illness, then we'll opt for another method. A head tilt chin lift will open the airway of most patients, so it's pretty simple and it works for most people. You can see the positioning of the hands here on the picture. We've got one on the forehead and we've got the other on the bony part of the jaw. Every time we're doing any sort of airway maneuver, it's all on bony prominences. So you go ahead and put the heel of that hand on the forehead and push back, while at the same time using your fingertips to lift upward on the lower jaw. Typically, once you do this maneuver, you have to maintain it. The head might not go back to the initial position, but it's not going to maintain itself in this position. Once you have opened the airway, then you'll check for the adequacy of breathing. In patients that do have suspected spine injury, we're going to use the jaw thrust maneuver. This maneuver typically will only work on somebody that's unconscious or relatively unconscious because it hurts. So you'll kneel above the patient's head while they're in that supine position. You're going to grab the angles of that lower jaw and slide upward. You're going to use your thumbs to actually help position it where it's supposed to go. And I've got a picture here. So you have hands on either side of the face, thumbs up. You're going to grasp that angle of the jaw. You have your thumbs on the zygomatic arch, or those bones within the cheek. You pull your fingers up, pushing your thumb down, and then you end up opening that airway. Once you open the airway, it is possible that they will begin to spontaneously breathe again if they weren't initially. And then you have to assess the adequacy of those respirations. To open the mouth, what they recommend is using the cross finger technique. We don't just want to stick a finger in and wiggle it around. Just like like alligators and crocodiles, we do have a reflex when we're not completely unconscious that if something is placed in our mouth, we have a tendency to clamp down on it. And you certainly don't want to lose a finger because we do bite with enough force that you can cause a severe finger injury. So you're going to put your thumb on one, either the upper or lower jaw. You put your index finger on the other, and it kind of depends on where you're positioned. This one says place the index finger on the upper teeth and thumb on the lower. That would be if you were at the top of the head. And then you're just going to push them opposite of each other, creating an X with those fingers, trying to open the mouth. That keeps you from having too much of your finger inside the mouth so that if they do bite down, you can either get your fingers out of the way or you'll have just a minor injury rather than actually having part of a finger clamped off. Suctioning is very important. Patients tend to drool, vomit, etc., have blood, mucus, all those other things in their airway that's going to prevent them from being able to breathe efficiently. And if they do have those things, you definitely don't want them breathing them into their lungs because this can cause infection, this can cause obstruction. So we have portable and wall-mounted suctioning units. The one all the way to the left is actually a hand-operated one. We have to clear that stuff. So suctioning is super, super important. Whenever you hear gurgling, you need to suction. So a portable or fixed unit that is not manually controlled, should have a couple of parts to it. So you should have a wide bore, thick-walled, non-kinking tubing. You should have a plastic, rigid pharyngeal suction tip. So pharyngeal just indicating where it's going to go. You should have a non-breakable disposable collection bottle. Usually it's a relatively large bin. And once you put a whole bunch of nasty stuff in there, you don't want it to break. So you want it to be pretty strong. And then you should have some sort of water supply for rinsing the tips. Typically, we use saline just to clear the tip out so that it doesn't get obstructed and it can keep doing its job. You want to inspect your equipment regularly. Make sure that it's going to work the way that it's supposed to. You have a couple of different types of catheters as well, so you want to make sure that you have them. You'll see a couple different types in your book. Some work better for adults, some work better for kids. They all kind of have their place and time for being used. When you check your equipment, you need to test the suction of the unit. You want to make sure that you have a vacuum pressure of more than 300 millimeters of mercury and more than 40 liters per minute when the tubing is clamped, so that you're actually doing appropriate suctioning. Your technique for suctioning, you do have a maximum amount of time that you should suction because as you're suctioning, you're pulling things out of the airway, and that's not going to allow air to get in. For adult patients, no more than 15 seconds. For children, 10 seconds. For infants, 5. If you suction for too long, they're going to become hypoxic. They're going to have hypoxia. So you're going to insert your catheter, you're going to obstruct the tube, and you're going to suction on the way out for no more than those maximum time limits. If you need to clear more out of the airway, there's still stuff in there, then you're going to allow them to oxygenate and then repeat attempts. You just don't go back to back to back.